Good morning, everyone. So, welcome to our second monthly Treat IR live case. We're here from Mount Sinai, New York. To my left is one of my partners, Dan Shilo, and we're going to show an interesting case today of a filter removal, but it's a bit more than just a filter removal. It's a bit tilted. The other Dr. Patel, and Dr. Nowakowski and Dr. Puneet Rana are going to introduce the case shortly. We have Mona Ranaday also joining us on the Zoom from Mount Sinai. So I'm probably who used to be at Mount Sinai, who's now at
Fire
UCLA.
Mountain Spider-Man.
She's moved
Higher
on.
Mount
Oh,
Sinai.
wow, she's wearing the Mount
Mount
Sinai
Sinai
swag right
Show us
there.
some swag.
Exactly. So now she's IR extraordinaire at UCLA, and she's going to help us give some commentary on the cases. So again, back to Scott and Raj. So there's Dr. Nowakowski, the other Dr. Patel, um, and Dr. Rana, who's sort of hiding there in the corner.
So I'm presenting a case of a 62-year-old male with IVC filter placed in October 2023, who's here today for a retrieval. He has a past medical history significant for HIV, hyperlipidemia, hypertension, fibromyalgia. Social history includes tobacco use, substance abuse, and also alcohol abuse. No known allergies. In regards to the history, he was admitted back in October for shortness of breath. He was found to have a right upper lung cavitary lesion and intermediate risk submassive PE. Patient was started on heparin drip. Hospital course was unfortunately complicated by submassive hemostasis requiring bronchial artery embolization, which resolved post-embolization. And then hospital course was then further complicated by rectal bleeding. So multidisciplinary discussion with the PERT team resulted in consensus of placing an IVC filter. Patient underwent transfemoral option IVC filter placement on October 9th, 2023. Prior to discharge, patient was then transitioned to Eliquis. Currently, he's tolerating anticoagulation without any further episodes of bleeding. So he was referred to us for evaluation of IVC filter retrieval. The initial imaging shows infrarenal IVC filter that was placed via transfemoral access in October 2023. There was 19 degrees of tilt in relation to the IVC, and non-invasive imaging CT venogram was obtained that demonstrates no caval or IVC filter thrombus. There is angulation of the filter with concern that the tip is embedded in the IVC and like the medial wall of the IVC. Here are some coronal and sagittal reformats that kind of demonstrate the IVC filter position.
Get a 12 French sheath, 1230.
So assessment and plan, this is a 62-year-old male, history of PE with contraindication to AC due to hemorrhage, status post-IVC filter placement. Patient is now tolerating AC without further bleeding. So the plan today is for IVC filter retrieval. Considerations for him in particular are, this filter has been in for at least 6 months now, and there's approximately 19 degrees of tilt, and the CT is concerning for an embedded hook.
Thanks, Puneet. I think Raj and Scott are still working to get everything set up here. Dan and Mona, both when you guys, so obviously we have not necessarily a filter clinic, but we try to take a lot of care in making sure any filters that we placed, we put the note into the chart and stuff and try to get them to follow up. But when they do come to follow up, what are you doing for pre-op imaging or anything like that, especially in someone who's on Eliquis or not on anticoagulation?
At UCLA, we have monthly filter clinic meetings before the patient even comes to clinic, where we triage all of the lists of essentially of patients that have had filters either placed or retrieved. And we kind of document on a monthly basis in this Excel spreadsheet all of our lists. And then everyone that got a filter placed gets triaged into the bucket of straight to procedure for removal if it's uncomplicated. If it is complicated, then they need to be seen either by NP clinic or a physician clinic. And so we kind of also segregate the patients based on complexity and, should they just be seen by an NP to make sure they understand what's happening. And then the ones that come to the physician clinic typically are someone that's going to require a little bit more of, retrieval, forceps filter retrieval kind of discussions. And So all of that goes into play
Okay.
before we bring a patient back.
And can you talk a little bit more about what you consider complex, when you think it might be complex?
Okay.
Like, what are your hard cutoffs for? Usually, like, if somebody, like a sample hard cutoff for me is if somebody else has attempted retrieval, I will almost always, unless I have like those fluoral images and I'm really confident, I would get a CAT scan. What are some of
Maybe another
the, hard
180
stops for you in
amperes.
terms of
Let's note it up.
complex and you would get more imaging?
I mean, majority of our patients are, someone's that we're seeing may have a history of cancer, may have had bilateral lower extremity DVT at some point. They might have had, prior filter retrieval attempts that have been unsuccessful. So we usually work them up with a duplex ultrasound of their legs to make sure that the veins are actually open, or if they're not, then we want to know that. If someone is a candidate for reconstruction, we might have that conversation with them at the same time. And then we want to also understand what their essentially history is in terms of where are they in their cancer treatment journey. I guess if someone is a neurosurgical candidate, should we be taking this filter out right now, or are they ever going to be able to tolerate anticoagulation? Things like that. And so essentially, CTV for anyone, like I said, anyone with history of cancer, anyone with prior DVT, anyone with prior retrieval attempt, anyone that's had filter for greater than a year, anyone that has a tilt on their
Okay.
filter
Good.
that we think
Good.
is whatever point embedded, or if they're extruding filter struts, they're all getting CTs. And then unless they're truly just, simple retrievals based on when they got placed, which is,
Okay.
we don't
Try
see
it.
a whole lot of that.
Yeah, I'm the same way. I have a pretty low threshold to get a CT. I think more and more, I think medicine in general is going towards,
Okay.
getting a lot more axial imaging, in terms of pre-op for these things. Filter retrieval, obviously the clinic visit is really critical. If somebody's coming in, as soon as I stop my
Okay. Yeah.
AC with a filter, I had
Bring
really
this guy
bad leg
down.
swelling. That's something you'd really want to investigate further. So just getting a CT venogram can save you a lot of trouble.
Let's
Obviously
bring
we
this
have,
guy in.
thrombectomy technology, which will allow us to really treat things in real time, but going into it, that allows you to, talk to the patient and prepare for things, in a way that you otherwise wouldn't be able to.
If there's any clot within the
Yeah.
filters, are you guys, making use of any of those
The
distal
retort.
embolic protection
Right?
and then
Retorker.
retrieval at the same time, or do you just anticoagulate and then bring them back?
It depends. I think for if it depends on how much clot there is. If it's just a little bit of clot like hanging off the top, if they're not on anticoagulation, I'll put them back on for a short period of time and then rescan. Although I find invariably the clot's still there. It seems like it doesn't really get rid of it, but that's sort of what the textbook answer is to try the
Microdose.
anticoagulation. If it's a lot of clot or the filter's obviously occluded, then I don't think AC is going to work, and then we have to sort of work work through as an
Direct
occluded
device.
filter, a truly occluded filter.
Yeah, I mean, I think we're in a kind of a brave new world here over the past few years. There were kind of the guidelines, if you see
Oh, it's okay.
something, send it
Bring
back,
it back.
AC for weeks. But
Yeah.
now with large bore
Yeah.
thrombectomy,
Bring
we
yours
have at
back.
least the
There you go.
opportunity to kind of act a little bit more proactively and kind of and treat these things a little bit
Yeah.
more
Come on up.
aggressively.
Yeah.
But
All right.
again, I think
Now
it
let
comes
me see
back
if
to
I
like
can.
being prepared for that and really knowing what you're
Yeah.
getting
Go
into.
ahead
And I
and
think with
just grab it. Yeah.
the pre-op imaging is really critical for that.
So back to the case at hand. So Scott,
Yeah.
Raj. So so it sounds like looks like here you're trying to do a hangman technique. So what's your thought here on what you're trying to do here?
Yeah. The welcome everybody. Just want to talk here while we're working on this. Exactly. Since just like I think Puneet had mentioned, we actually felt that this is a complex or classified as a complex retrieval because it is embedded and slightly tilted. So we thought we would go right to one of the complex, one of the maneuvers that we use for complex retrievals, which is the loop snare or hangman technique. So we basically forego forwent the standard snare technique and hoping we can just get enough of this. But that the apex and the hook are pretty embedded in there. So
Do you guys want to talk a little bit about
yeah,
your
I want to be a
setup, kind of
little
what the
higher.
thought process
So
was for that, your
yeah,
sheets or, how you chose sizes for everything?
yeah. So
I mean,
I think that it's a good idea for these to go ahead and do a jugular approach to first uh, obviously we can also consider doing a femoral approach. And actually, what I like to do is just go ahead and do a jugular approach, but have the groin prepped. And so we have that here. And then just do a cavogram and really get a sense of. Let me just see if we can just grab this wire. I'm gonna just we're gonna just try to see if we can get a sense of whether the standard technique is going to work and give it some time. And then obviously we have an escalation of techniques. And so we're sort of on what I would call from the first to the second step, which is to go from the standard snare to to the hangman or loop snare technique. What does the panel think about the success rates in these kinds of patients with the hangman technique? Do the panel think that they think it's going to work most of the time? What's been, your experience?
So I've been going more and more to going to forceps. I mean, I think we have a lot of tools, and just I find more and more I'm just going straight to forceps and trying to angle it. In terms of your access, I think we had talked about accommodating that. We had been
Yeah.
talking before. I think most of us are using some version, depending on how big we need to go, from like the 1645 or 1840
Up
hooks,
higher.
and then up to the 20 centrons if we have to. And that accommodates that. And like I said, I'm pretty quick to forceps.
Yeah, same here. I'm
Me too.
fairly quick to go to forceps just because ultimately I don't find the hangman works all the time,
Yeah.
or sometimes I end up getting the wrong part of the filter and ends up making it a bigger mess. So I have a low threshold to
Yeah.
go to the forceps for these types of filters. Now I think for other types of filters, I think the story's a little bit different. So I think for the sort of optes, trapeze
Amazing.
kind of thing, or even for green fields, just because you can't necessarily get enough grip with the forceps,
Yes, they
it's
are.
usually a combo technique of using hangman and forceps. You may need both techniques
Yeah.
to get it to work. But how about you, Mona?
Yeah, I think same. For these type of filters, I would probably go to forceps within the first 5 minutes of trying. But I do think that, I have had patients where I have not had them under general anesthesia and they have reacted with the forceps. And
Yep.
sometimes it just really, you could be in there with the forceps kind of just even every movement the patient realizes, then at that point I have, you know, attempted to try and just do it with the hangman technique, and it does kind of work to try and peel that filter, y basically towards the center of the cava, a number of times. It just takes a lot, I think, of patience and
Try with concerts right there.
persistence.
A concert.
Yeah.
Well, now that you're
Concert.
UCLA, I think you have to use hangman a little bit
Let's
more,
try it.
right? Isn't that kind of
Let's
obligatory?
try it.
But, yeah, I mean, I think it like you said, it depends a little bit on the filter type. Some of them, you're gonna have that closed cell portion, so you can't necessarily go all the way
Yes.
up, and that could actually tilt it a little bit more. The option specifically, unless you wanna go into the closed
Ex-
cells that are at the top, it could be
True.
difficult, whereas other types, like a Select or anything where you could hangman all the way to the top, it might be, yeah, a little bit easier. I think for me, personally, I think having a timer on is really important for me.
Are you guys
I mean,
getting,
uh,
terminal access at the same time for most of these, or you kind of just prep it and, get it if needed?
I sort of prep and hope for the best. So it's ready to go, but usually I would say most times we're able
yeah.
to get it from the top. Sometimes if it's really embedded or really hooked, it's sometimes a bit tricky. It always comes out from the groin, but it's always a bit nerve-wracking pulling it
Yeah.
out that way. Yeah. And again, I think Mona makes a good point. I think we have a very low threshold to use general anesthesia for these cases. Obviously, the more complicated it looks, the more likely we are to use general anesthesia and go from there. As Mona said, the patients do really feel the forceps, and it's really hard to predict who's going to feel it and who's not. And some people react very badly to it.
Do you find that helpful at all? I know, so at meetings, especially a couple years ago, a lot of folks were saying they kind of enjoy not having the GA because they get a little bit of feedback. So if somebody reacts, I don't really find that helpful.
No.
Some folks were saying, people that were kind of experienced operators, if they're reacting more than I would expect, then maybe, I'm doing something I shouldn't be. I don't personally find that helpful, but
I haven't run into that.
yeah.
So Raj, just in terms of your setup, in terms of doing
Yeah.
the hangman, so it looks like you're using a reverse curve catheter. You switched to it looks like switched to a sauce just to give you a little bit more control over
Yeah,
the
we
wire. And then
switched
what?
to a contour here,
Okay.
and I agree with all the comments about the hangman, but in particular your comment, Rahul, about sometimes I find that even when we can successfully sort of accomplish this hangman, I find that you wind up sort of pulling up on one of the one part of the filter, one of the legs comes up, and instead of really pulling the hook cleanly off, and so which is what we're obviously trying to
Yeah.
do. Yeah, I'm just going to get this down a little further. Yeah. This, so I like to use a glide wire and a reverse curve catheter, just like you were saying, and then just
Yeah.
grab it and then just form that loop snare and try to see, just having a little
I don't know if you
issue
mentioned it. You
here with
said you have
this.
what size sheath do you have in the neck
Well,
to start?
well, we have a 12 right now
Okay.
because we have the 6 French gooseneck snare, and I mean the tri snare,
Triple.
excuse me, and then we have the 5 French, contra,
Yeah.
to get us. So let's see if we have it here. I think we might have it here. Uh,
I think you're close.
just spin that and
Oh,
Really important for these
too
to
much.
use a glide wire, not use something like a Benson or implants or any steel core wire, because you can definitely mess those
Yeah,
up.
exactly.
So I just want to make that point for anybody who doesn't have
and
experience with this. Yeah.
and again, I use a floppy glide as
Yeah.
opposed to like a stiff glide, right? So it doesn't
Mhm.
less likely to flip out your
Yeah.
sauce. Yeah. Have you used just out of curiosity? Have you used the tip deflecting sheaths at all?
Well,
Any
that's
experience with
interesting. I have not. That's very
Yeah.
No,
interesting.
I haven't done it for these.
Yeah, like the Oscor sheets. Yeah,
Right.
I know people have talked about it just because you can just hook it and just sort of drag it back.
Yeah,
Thanks.
it's a great idea. I mean, I've used like angled guides to get a little bit more angulation, but not a tip deflecting sheath.
Yeah. I've used a tip
Yeah, I
deflecting
Still
think
have
guide.
laser.
Yeah.
Are you
any
guys
French
using
is this?
laser or considering laser?
So we don't
What
use the
French is this?
laser really that much or at all. We just sort of use brute force. We're sort of,
Well, you still have to get around the hook in
yeah,
order to use
exactly.
the.
Yeah,
I think a lot of these cases are you
yeah,
still, need to get it
Right.
kind of
yeah.
attached on the embedded
I
portion.
I haven't found a lot of need that I was like, oh,
Yeah,
if I
just
had the
spin
laser, I
that.
would have gotten this filter out. I don't know if your experience is different. Usually, we just sort of pull really hard and it comes out.
I mean, I think one of the big benefits of the laser isn't necessarily to get things out like you're saying that we wouldn't otherwise. I think it allows you to do it with a little bit less force.
Yeah,
But I think,
yeah,
I think with experience, you kind of get a feel for it's kind of what we were saying about feedback from the patient. I think over time, you get a feel about what feels right and what doesn't feel right.
yeah.
And you can kind of change around what you're doing if it really doesn't feel right. Mona, how's your experience with the laser been? What's good? What's difficult?
I
Okay,
haven't
pull it
really
in.
had much success there either. I think, like I said, it's I think a lot of times the
Let's go
tip
with the wrist shot.
is very
Okay.
embedded or very tilted,
Yeah,
and you
we got
need
the
to
wire,
straighten it
guys,
out.
so we're gonna
Yeah.
try
Yeah,
Yeah.
pull back
So
on
it
the
looks like we
hangman
got
now.
it here.
yeah.
And let's see if we're just going to mag this up and let's center this so we can see
Make
what
sure
we're
it's
doing
tight.
here. A
It's
little
tight.
bit better.
Make sure it's tight so it doesn't pull out.
Here we go. Let's just see if we can just grab it here
Yep.
and maybe at least displace it.
Yep. See it's straightening a little bit and
A lot of times in these type of cases too, I'll use a larger sheet because as we're seeing here, sometimes you'll get the neck of the filter to come in, and then the hook is still kind of sitting outside of
Inside the
the.
sheath. Yeah, yeah,
Um,
yeah.
so you can kind of oversheath it with a larger. Um,
You got it?
Yeah, I was actually having this discussion with my fellow yesterday. I was like, like what size sheath to use, and I was like, what size sheath do you want to use? And he said 16. I'm like, all right, great, go 18, because it's always you always feel like
Okay.
you're one size too
So
small.
let's grab
So
this
just
one.
yeah.
And then I'm
just
going
go
to
one size
change this.
bigger. It's a vein. It'll 16 to 18 is not a big deal.
More forgiving.
Like
Yeah.
how we winkle after all, it must have been that
So
you
we can
trained
get
me or
I
something.
must be. It must be.
Go big or go home.
Yeah. Yeah. I mean, we've definitely been burned, especially because the sheaths that you have, the different sheaths you have from the neck are somewhat limited. I mean, Argon does have a new sheath, which we haven't used, that dual lumen 16 French
Mhm.
sheath. I haven't used it yet, which is a little bit more reinforced in an appropriate length for doing sort of the jugular work. But for like if you want to use forceps from the neck without that sheath, you're sort of limited to the Cook sheath, and that sheath's not really reinforced. And
both.
you've had it strip and tear and get stuck in very bad places. So from the groin, it's not such a big deal because you can use the lengths aren't as big of an issue. So Roger, what are you doing here?
Yeah. So look, I don't know if you can see this, but you
Another
see
glide.
we have the glide. It's a 180
Okay.
glide.
Yeah.
And we've
Let's
taken
fix
out
that,
we've basically
Ah,
obviously
that's-
pulled the
that's-
wire out using the
Good
tri
decisions
snare. And so
going
we have one end here, and then we pulled out the contra also. So now all we have is just the wire, the nitinol wire, so it doesn't kink, of course. And now we're just ready to go ahead and see if we can just basically just get this off of the wall.
Mhm.
And Raj, in
And
terms of your setup there, so it's exchange length or it's 180, your glide wire?
it's a 180. It's a
Okay,
180.
and you have it
It's
clamped
an
on the
exchange.
ends? Like, how do you
Yeah.
Yeah.
usually
Can
we
you see
like
it
to
here?
just if you can show
Puneet has them
if you
both
just
here.
wanna show folks, if you can zoom in on the camera, just kinda how we clamp them.
Yeah.
It's kind of a standard thing we do for any type of snare, but it gives you a nice handhold on it as well.
Can you see it?
Cool. Just
I
yep,
don't
just
think
a couple
I
forceps down
have
there.
the.
Yeah,
You can use
Good.
anything.
yeah.
Good.
Cool.
Oh,
All
okay.
right.
Just don't use the
Yeah.
scissors.
Yeah. Exactly. Okay, so
Yeah.
look, let's see what we can do here with getting this off of there.
Yeah.
Okay. See, this is the thing with it.
Right.
we
It's so
created a
embedded. It's sort
horizontal
of
platform to
Yeah. Now
use
we've made
our
it just like
forceps.
you were saying earlier, Rahul, and
yeah.
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 So it's just like Scott is saying, it's horizontal. So
Yeah.
yeah.
It's a
All right,
little
what
hard to predict
what
which
should we
way.
do
Yeah.
here?
Yeah. It's sometimes, like I said, it's a little bit hard to predict exactly which way that thing is going to cantilever and turn. Right. You hope it flips the nose, the cone of the filter
Right.
to the right, and a lot of times it just tilts to the left, and it gets worse. So yeah, I think at this point you're sort of stuck. Right. Like you're going to have to go to forceps here, sort of give up the loop snare.
Yeah.
Yeah.
So I think that's what we're going to do. We're going to go ahead and just, you know, Debbie, could we trouble you for that 18 French sheath? So, I think we're going to have to go here now to the. Is anybody in the
18
panel think we
18
should
French sheath.
continue with this?
Yep.
Because I just think that we're going to actually just wind up making it even more sort of distorted and
Yeah.
disrupted the culture
Yeah,
itself.
I
So I
definitely
think
think
I
going
think
to
most of us would
forceps
just
here
go on.
would be
And
Yeah.
also,
Yeah. I think most of
Okay.
us would
Okay.
go
Good.
on as well. Yeah.
Yeah, so let me see if I can just show it here. So this is the Limol, forceps 4162, and this is it has the white handle. So this is the one that we want. It's 60 centimeters long. So you want to make sure that your sheath is 40 or 45. You don't want to have the sheath be too long. It has a 3 millimeter shaft,
Okay.
and then the jaws themselves are about between 4 and 5 millimeters, and then it has this sort of alligator teeth, and has this articulating arm, which you can control with the handle here, and then it has this sort of more straight arm. And the idea here is to get this in there, and then to just sort of turn it. I mean, the technique is basically to turn this and sort of, displace the tip of the filter off of the wall, off of the cable wall, and then go ahead and, of course, grab the apex and the hook, which probably in this case has some, an endothelialized tissue encasing it. So that's what we're going to be doing here. And, these will go through a number of different sheets, but we like the 18 here.
Exchange
Mhm.
it up.
Go ahead.
So, Roger, I know we talked about a little bit this earlier, about there's different pitfalls and things that can come up with the forceps, right? So one thing
Yes.
obviously is they come straight. So the straight doesn't usually work because you got to get it off the wall. So we put a little tilt on it. And
Yeah.
then, yep, they can be sterilized. So we can use them again. One of the big issue we have right now is don't throw them away because you can't get them, or they're very hard to get. So we have our certain number. They sort of lose their grippiness after a while. So we have a couple that are
Why'd you
not
take this out,
as
Yeah.
gripped
Why'd you
as
that's great
others.
then. Yeah,
So Raj, you
I
said you're gonna
think
go
we
up
have a
to
slide.
the 1840?
Yeah, we're gonna exactly.
Okay.
The wire is a little bit trapped in the filter, so we're just gonna actually need to
Mm-hmm.
sort of disengage it a little bit.
Sure.
So we're just gonna get a catheter down because it doesn't want to just sort of slide off so easily. The loop, I think, is just
Simona, what sheath do you
oh
use
my God.
if you use the forceps from the neck?
I'll typically go with a gore dry seal, a larger one like a 20 or a 24, and then put a 16 through it. But I tend to do the dual sheath technique to get over the embedded or tilted hook.
Yeah. You do that just so you can get you can just rip the whole thing inverted into the sheet.
Yeah.
Yeah. Not a bad idea. Yeah, my concern with the dry seal, obviously you put the 16 French through, is that you're going to tear the valve coming through, and it just becomes a
Yeah.
mess. Yeah. They work well from the groin for doing like the inversion technique.
Once I'm going forceps, I've just gone to either like like we said, the 1645, the 1840. I've actually found in tall patients that extra 5 centimeters in the 1645 can be helpful.
Yeah.
And then, yeah, from the groin, if we're doing filter reversion, which we can talk about a little bit later, that's going to be usually a 20 or often a 24 centron for that. This is the 1840 Cook.
So actually, there's one thing we didn't talk about. Raj, did you hold the anticoagulation for this patient, or did you just keep it going? Because now we're gonna sort of more rip this filter out as opposed to.
Yeah. No, you know, my protocol has really been to just keep these patients on the anticoagulation, and I just leave them on the anticoagulation, obviously during the procedure, and even afterwards, I ask them to continue it so that we can we can basically, we just don't want obviously things building up on our system,
Yeah.
clot and all. So that's why, and I like to leave them on it. And even if they're not going to be on it anymore, I do leave them on it for even another 2 weeks afterwards.
So that, as you can see, I probably have some wall here or some fibrosis. I'm not around it, but the filter obviously is moving, right? Um,
And so one of the
let's just
benefits, I think,
see.
because it's an optional lead, it's a single cut nitinol, and so if you do have to ragdoll it, if you do have to kind of grab in the middle and get into the sheath, it'll be more forgiving in terms of coming apart, I think,
Yeah.
than some of the more previous welded filters. I think it provides me, probably falsely, a little bit more comfort if I'm doing an E version and I know I have single cut nitinol. Then it makes me feel just a
Yeah.
little bit better.
Yeah.
No, there's no doubt that it feels from below, and just inverting it is really might even be viewed as being easier. Again, I'm still just next to it.
I guess coming
The
from
nice thing
below, where you're
also,
coming right at the
Yeah. You just come right up into the
coming
apex.
right
yeah,
at the yeah, exactly. That
Yeah.
that makes, but just like you said, just worry if it's gonna fracture. The nice thing about coming or having the forceps, if it does fracture and there's a strut that's sort of left in place, with the forceps, you can usually go back and just pull that out, so you get the whole thing out. Pull it out hopefully before it embolizes.
Trying to go in a little 360 here to see what the best angle for this puppy is.
Yeah. There you go.
So
Well,
this
yeah,
is kind of,
Promising.
looks
yeah,
pretty
that might
good.
be. Oh, you
Yeah,
can see
Yeah.
right down the barrel
yeah,
there.
yeah,
definitely.
yeah.
All right, all right.
Like a mama tiger getting a cub, just by the neck.
Yep.
And now it's
So,
just brute force, right?
so I think
Okay, so what I've actually done
but,
is I may have
You've
split,
split the
Yeah.
yeah,
filter.
that
Yeah.
sliced
Yeah.
the sheath a little bit. All right,
yeah, I think the sheath might be a bit.
all right.
And I had that happen with this sheet
Yeah.
before.
Yeah.
Like,
You have?
Oh yeah.
yeah.
Because it's not reinforced, right? So you may
Should
end up
I
having to
leave
take
it
it
go?
out just from the groin, right?
Yeah.
Yeah, yeah.
And just
It's
invert it.
still another way.
Um,
Or if you just let it go and then
I
just try
mean,
to
I feel
reposition
like
the
you
tip.
could, let it go and kind of
Yes.
walk it so
These
that
don't
it
fly.
straightens
Yeah.
out.
Yeah, you might be able to try to walk it, to get
Yeah.
the hook,
Yeah.
I don't know.
If you have
Like
more
going
of the
into some,
forceps
but
out of the, yeah.
Yeah, I don't think. But the
I
thing is, I
think
think it's so tilted, it's not going to
yeah.
straighten, right? Yeah, and I think
um,
your sheath's so buggered. Yeah, I don't think it's going to work. I think you're gonna have to do it from
Yeah,
the
the sh-
groin.
Yeah.
Yeah, I wouldn't drag it too high because you're never going to be able to get it from the groin, right?
You know, you're in a position right now where you have a hold of it. It's not going to go anywhere. So you can always kind of come from below. You can always grab it or even snare it just for
Yep.
stability,
the forceps.
to make sure it doesn't fly.
Yeah.
It's always an
Agreed.
option. So you're in a stable location right now with a good hold on it.
Maybe we can.
I don't
Yeah,
think we have
although
a
I think right
second
now it's
forcep.
pinned. Right now it's sort of pinned, right? You could use the
Yeah.
other sheath to pin it. Although now,
So are you guys gonna try to go from the groin, or are you
Snare.
guys gonna? What's the thought process now?
Let's get it from the groin.
Yeah,
Raj.
I think that's the best way. Is just go
Yeah.
ahead and just we have the groin
the other
prepped,
thing you could
and we're
do is
just
if you
gonna
don't
go
have the
ahead and get
forceps, is you
into
could
it.
hangman it from the groin and just
Yeah.
grab it, right, and then get the forceps, put a
Mhm.
20 French on
Right.
the thing, and then
Right,
grab
yeah.
it, right, to pin it once you can let
Yeah.
go of it. Yeah,
Well, I think the plan was always to do dueling
Yeah.
forceps. This was just kind of our opportunity to do it.
to show how shitty the how
Exactly.
bad the cook sheath
I
is.
mean, this is exactly how we drew it up. I mean,
Yeah.
Guess, does anybody think that some of the other sheets, this may not have happened, where it, sort of
I think if we had
gets
done
sliced?
Mona's trick with the gore, it might have not tore the sheath because the gore is pretty tough to to shear like this? The cook sheath's pretty thin.
Yeah, I think that's kind of what we were talking about before, where there's limited options. I think the centrant is a lot stronger, but like you were saying, you just don't have the length. I think 28 is the longest it comes in, right?
28. Yep.
Yeah, so you wouldn't really have the length.
Yeah,
And like I was
that's
saying,
right.
even the 45 over 40 can be helpful in taller patients. So the centrant just isn't going to get you there unless you're coming from the groin. I mean, there are really outside the box ways you could try to do something from like the left neck if you were going to snare, but I really think that the best way to try to at
I
least
think
stabilize
Scott's
it is
trying
going
to
to be from the
straighten it
groin.
out right now. Oh, it's
There we
straight.
go.
It's
There we
straight.
go. Yep. We
I'm
got it.
trying.
I
Yeah, got it.
I got it. Okay.
Oh, nice.
So I
It's
let
also the
go
threat.
and exactly. No, I actually let
Thank
go of it
God.
and then grabbed it closer to the hook.
All right.
Yeah.
And the archie
Excellent.
blows.
Right.
Ah, nice job,
Strong
Scott.
work.
There
All
you
right.
go.
Nice,
You want to
nice.
save that fluoro and show it, and
Yeah.
kind of Scott, you want to talk
Yeah.
through kind of what you did there? I think it's really important to kind of talk through what you did there and how you got yourself to a position where you can
No,
get that.
absolutely. So I mean, obviously the issue was the fact that we had
Can we play it?
filter on either side of the graspers that was acting as sort of this cutting device, right? With the sheets. So I just let go of where I was, which is about
Let's get
half a centimeter from the tip, from the hook. And I just sort of angled a little more, grabbed actually the hook because it was in a better position to grab. And then it sort of converted itself to just being straight and coming out as opposed to being this big cutting device.
So here's
Right.
the filter just to show, that all the legs are here, all 6 legs.
I always, get a single shot or an X-ray of the chest just to make sure there's no legs already there, and then do it at the end just to make sure all the legs are there. Count the legs, kind of thing, because I don't want to get blamed for broken legs if it was there before I got there. So
100%.
Right.
And actually,
Prior
for
filter retrievals and even
Yeah.
wires, prior
Yeah.
wires can be.
Yeah.
any filter that's a couple years old, especially if I only have a CT, I mean, you can see it on the scout. I'll literally just mag up almost to the side of the screen and take 2 orthogonal 1Xs.
Yeah.
Um,
Looks good. That's just bad.
Yeah, there was a vein there. That's
Yep.
what that
Yeah.
was. Yeah.
Yep.
Yeah.
gorgeous.
Looks good.
And anesthesia, hemodynamically, how are we doing? Thumbs up from anesthesia. So
Yeah.
that's one of the things too, is
Most
to see how they're doing hemodynamically. Exactly.
Yeah. Simple questions like, what are you gonna do? In terms of removing the sheath, are you just gonna hold pressure, purse string, mattress suture?
Usually for these, I just hold pressure and just make
Yeah.
sure that they're upright.
Yeah.
And that should be enough for them.
So-
I think we're just going to go to the slides for a second, just real quick, and then
And one
some
last thing, by the
closing.
way, 6 legs on here. So we always
Yeah.
photo document, take a picture of this and add it to the chart. So, and as mentioned earlier, also take a look at the lungs, make sure there's nothing there. But yeah, so we always photo document these just to make sure there's no issues or questions.
Just some of the tips with the forceps, just especially when you're coming from the neck, it's possible. We just go to the image showing the forceps first, and then, or even this one here is good. Is that it's easy for the sheath to get displaced into certain veins. Not sure if you can see it on the screen here, but
It's
we
a
have
beautiful
a couple
shot
of
of the
images
gonadal
of
row.
yeah, of the sheath sort of, inadvertently once you get the wire out
The
to,
forceps and the gonadal.
fall into and then the forceps and the gonadal too, exactly. So, one of the things you want to sort of be mindful of is where your sheath is. You could certainly use a buddy wire that would help. And, in some cases, depending on how big of a sheath you have, that might, be useful here. But just sort of keep these things in mind. Know where your sheath is, know where the forceps are, because obviously, having operator experience with this is really critical.
Thanks, guys. It was a great case.